I'm going to start this video off by saying that I am completely biased, but I personally think that they are the best place for you to get what you need to get in terms of experience prior to starting CRNA school. So, like, for real, I do think that. I floated to other units, the regular ICU, CVICU, burn trauma. Never floated to neuro though, but I will say that a lot of those nurses have gone to my unit, the CVICU, to learn about the SWAN and some other things to prepare themselves for their interview for school. So while you are getting a lot of experiences and a lot of different experiences in those units, I feel like the CVICU is like everything you need. Bundle up in a nice, little blanket, and it's just a great place to work. So a little bit of background about me. I started in the CVICU as a new graduate. So I graduated in December of 2013. I then took my board January of wait a minute. Did I say 2013? Okay, let's start all over. I graduated in December of 2013. Oh, I did say that. I took my boards in January of 2014 and then started in the CVICU in February. I got my foot in the door by becoming a student nurse intern my senior year of my nursing program. They have this internship program for nursing students, and I went into the human resources department and she asked me, oh, what unit are you interested in? I'm like, I want the sickest unit that you have, please. And I got placed in the CVICU, and those patients were sick. She wasn't kidding. 6 months of orientation for the CVICU. We have to take the Essentials of Critical Care orientation, I think it's called, through the AACN, and then we also had various classes that we had to attend, like EKG courses and just learning those medications that we use on a day-to-day basis, like vasoactive medications, the ventilator, ABG interpretation. The orientation was very rigorous. However, being on the unit prior to actually starting as a nurse definitely helped me because I kind of knew the unit, I knew the staff, I knew the medications that we utilized, I knew the acuity of the unit, and it definitely was a seamless transition for me to walk from being a student nurse intern to a nurse. So I think that if you can get into the ICU prior to actually being a nurse as a patient care technician or externship, internship, what have you, please do it. So the type of patients that you see in the CVICU generally roll right in directly from the operating room. They don't take any pit stops. We don't stop in the PACU. We just go right up that elevator from the operating room to us. And they are usually a hot mess. So we get a report from the surgeon, from the perfusionist, from the anesthesiologist to tell us all of what happened in that operating room. These patients are on a lot of medications like epinephrine, Mironone, phenylephrine, Levophed, vasopressin, insulin, propofol, etc., etc., etc. And you have to know how to titrate these medications. So when we talk about autonomy, at least where I was at, we had autonomy to make those changes with those drips, titrate those medications up and down as we see fit. So when you have a patient that is on multiple drips, it's not just knowing to titrate this one up and down, but which one do you titrate off first? You're looking at not just their blood pressure, you're looking at their CVP, their PA pressures, their SVR, their cardiac index, and knowing what receptors work with which medications so that you know, well, well, their cardiac index is, you know, a little on this side, or their SVR is this, so maybe I'll, you know, go down on their neo and then go up on their epi, or maybe we can turn off this levo, they're not really responding to that, or let's turn the basal back on. So it's just like knowing how to manage those situations takes a lot of skill, because if you don't know what receptors are working for those medications that you're giving, you can't really make any good decisions at all. I remember I floated to another unit, and they had a patient on a cardiac drip, and one of the nurses came out to me. She's like, I don't know what is going on. I keep going up on my cardiac drip and my blood pressure keeps going down. I'm like, well, let's talk about how this medication works and what it works on. In addition to all of those medications, your patient will be intubated. So you are looking at arterial blood gases to look at what's going on with them, to see if they're ready to be extubated or not. Knowing when to call respiratory therapy and say, hey, let's go up on their FiO2, or hey, let's turn on their respiratory rate, or hey, let's change their tidal volume, things like that. When I was a travel nurse, we basically had a protocol that allowed us to extubate the patient without even calling the physician or the PA or the NP. Once they met that criteria and that we were okay with extubating them, we can just go ahead and extubate them if they had a good NIF, following commands. Off of, you know, all these vasoactive medications, things like that. So in different areas, you have even more of that autonomy. Other areas, it's still, you know, more structured, where you need to get that order for that extubation. Our order for extubation was always pending that they met those requirements that were listed. Patients will come up with chest tubes, tubes in their nose, or you'll probably have to put an OG or NG in. They might have some pacemaker wires. They have all of these extra things that can go wrong that you still have to pay attention to. Although you're over there organizing your lines, going up and down in your drips, you need to be monitoring their urine output and their chest tube output, making sure they're not bleeding out on you while you're fiddling with those things, making sure you're monitoring their blood glucoses every single hour, making sure you're drawing their ABGs, making sure you're drawing their labs, making sure you're replacing their electrolytes. There's a lot to do, and it is so much fun. And the best part about that is that their status can change at any time. You can have a patient that is doing so well, doing great, and then they code, and you're like, oh, really? But you know what to do, and you have a team of people that will run to your side and assist you with whatever you need. And it's just a great place to be. I love the CVICU, and I don't regret my experience a single bit. I think that I was fully prepared for my interview, and I've been given the foundation that I need for school. But in addition to that, we took care of heart transplants, total artificial hearts, ECMO, LVADs, RVADs, all of the above. And these are critical, these are super sick patients. When you're looking for an ICU to be in, you want the sickest patients to take care of, always. Because that's how you are going to learn. That's how you are going to develop your critical thinking skills and your knowledge base. In addition to that, when we do like induced hypothermia, some patients are going to be paralyzed and sedated using a bispectral index monitor to monitor their level of sedation. So you're also getting that anesthesia part of things as well, which they also do in other units too. Some other things that the CVICU taught me was how to talk to surgeons, how to collaborate with other, disciplinaries within the hospital, like nutrition, physical therapy, pharmacy, and how to properly advocate for my patient, because that's something that you need to do as a CRNA as well. You have to build that rapport with the patient and their family extremely quickly, just like you would do when you are pre-oping your patient and informing the family of what is going to happen. When those patients' families walk in for the first time and see their loved one laying there with all these tubes and drains and lines, you have to be able to communicate to the family, what do these numbers mean? What do those lines mean? Why do they still have a tube in their mouth? And be able to communicate that effectively and help ease their anxiety. So I think those, non-clinical skills transferred over to become a CRNA, and I have to do that every single day as a student when I'm talking to patients and their young kids, telling them that I'm going to be providing their anesthesia, I'm going to be placing that breathing tube and easing their anxieties and their fears. So all in all, there's a reason why ICU experience is required for CRNA school. I can't, imagine doing CRNA school without it. Like, you need it. It's beneficial. Most schools require a year of experience at a minimum. However, the average amount of ICU experience that most applicants have is about 2.5 years. So I applied when I had a 1.5 years of experience, and then by the time I started school, which was a year later, I had 2.5 years of experience. So that's something to keep in mind when you are applying. Some schools are okay with you having not a year yet when you've applied, to have that year when you start, or sometimes they do not like that and they want you to have that year at the time of the application. So that's also something to keep in mind. So in the comment section, let me know what unit you are working on, what unit you are interested in, and tell me what you like most about it, because I'm all here for the CVICU. It's the bomb, it's the best. I know other units are great too, but my heart is in the CVICU. So I thank you guys for watching. Also, if you have any questions, drop them below, and also follow me on Instagram at I am Nurse Nell. Thanks for watching again.